joining us today. On behalf of my co-chairs, Drs. Jenny Sheng and Karen Smith at Johns Hopkins, we'd like to welcome you to our three-part COVID and breast cancer webinar series. My name is Alyssa Thorner, and I'll be moderating this event for today. Over the next hour, we'll be discussing living with metastatic breast cancer during the COVID-19 epidemic. The ideas for these webinars came from many questions we were receiving from patients like you as to how treatments, protocols, and support may vary during the current climate. As a result, our team just published recommendations on COVID and breast cancer treatment in the Journal of Oncology Practice. This article is expected to be out very soon, but much of the information you'll hear today came directly from this manuscript spearheaded by Drs. Sheng and Smith and in collaborations with several Johns Hopkins breast cancer surgeons, radiation oncologists, medical oncologists, pharmacists, and patient advocates. Today during this webinar, we'll be discussing HER2 positive breast cancer with Antonia Wilf, triple negative breast cancers with Dr. John Fetting, ER positive breast cancers with Dr. Raquel Nunez, and supportive care with Dr. Sydney Dean. We'll also be hearing from one of our very inspirational patient advocates, Shantae Randall, who is living with metastatic breast cancer during this very trying time. And actually, she's coming to us directly from treatment. So Shantae, we so appreciate you being here. And we're hoping that you're going to share your story about how you're coping, staying fit, and actively treating your disease in these current very tough restrictions. Before I turn it over to Shantae, just a few very quick housekeeping things. I have your line and your camera's muted. Your camera's muted, your camera's off, and your line's muted. At any time during the presentation, if you have a question, please use the chat feature you see at the bottom of the page. Your questions will come directly to us, and we'll get to as many questions as possible before the end of the webinar. At the end of the webinar, we'd ask you to take a very quick survey. I'll post the link on the slide as well as in the chat feature. This survey should only take a minute or two to complete, and your feedback is really important to us to let us know how we can improve for future events and programming. And finally, if you miss any information that's presented in the next hour and you'd like to watch it again, we're recording today and we'll be sending out the link in the coming days. So that's about it for me to start. I'd like to turn it over to Shantae.
Good afternoon, everyone. Straight from the chemo chair at Skip Barrel on the 6th floor. I have had the interesting job of trying to explain what it's like to be a Hopkins metastatic breast cancer patient during these COVID times. It's been amazing in some instances, in some ways, and then it's been a little bit of some difficulties. But I'll go into the amazing part. At no point during this time have I felt like I've missed anything with my doctor, Dr. Wilkinson, or her team. They've actually communicated more with me now via email, or even if I want to send a message via Epic. I get a response a lot faster. They stay in touch with me in regards to labs and scans. None of my scans or labs have been moved. Treatment hasn't been delayed, except for I had a platelet issue, but that had nothing to do with COVID. And I've just been really pleased with the way that the team has made sure that all of my needs are met, or if I have a weird side effect, Dr. Wilkins even changed one of my telemedicine visits to an actual in-person visit just because I had a weird symptom and she wanted to check it out. The telephone calls, the telehealth visits are also set up pretty well. I didn't have a problem downloading the app or testing it to my phone. And we can see each other pretty well, which makes it almost like being in person. It's not exactly being in person, but it's almost like being there. And the one downfall that I did have during this time is just that being a chemo by myself. We have to come by ourselves, and this is actually literally, I was an early stage patient, and 2 years ago, and I've switched to being metastatic in 2019, and actually the first time I had to go to chemo by myself was during this, during the pandemic, and so it kind of heightened my anxiety a little bit. Because I usually use friends to talk me through the needle stick or the access of my port, and it lessens my anxiety. So my anxiety has been a little higher about being here alone and, just being safe. But other than that, it's been actually a pleasure, and everyone here has made sure at the Hopkins team that I've been taken well care of.
Shante, that's wonderful to hear. It's great to hear that we're doing well. It's great to hear that you're doing well. I definitely feel for you having to be there alone. I know this is really hard, and I definitely know that patients are feeling it, but it's good to see that you're doing well. Just a real quick question before I turn it over to our speakers. Can you talk a little bit about what you're doing to sort of stay healthy and what you're doing to stay active?
Oh, definitely. So I love my house and I love things in my house. So I was doing a lot of home improvement projects. I painted bathrooms. I have plans to change sinks and some things. I also started a garden. So I have some tomatoes, some green peppers. My daughter sent me some seeds. And so I have summer squash growing. I've planted some flowers. And I also am a gym buff. I used to love to go to the gym, especially even now, even throughout treatment. I like to be able to keep my health up. And so during the pandemic, I wasn't able to do that. I am not able to do that. So I take lots of walks, or I do stretches and weightlifting outside in the grass when the weather permits. And I've bought some home gym equipment. I have an elliptical and resistance bands. So by being physical in some way, form, or fashion, it helps me relieve a lot of the stress and the anxiety, because this pandemic for cancer patients is kind of like our normal anyway. We don't go out I didn't go out during flu season. So I avoided a lot of germs. So it's just, we had to be creative, a little more creative, because this is lasting longer than the typical flu season. So, but I stay pretty busy and try to enjoy nature.
Wow, you're quite the inspiration to us all. What remarkable things you said. So thank you so much for sharing. And if you're able to, I don't know what your schedule's like, but if you're able to stick around, I'm sure there'll be some questions later. But if you need to log off, no problem.
No, I'll be here. I got a whole
wonderful. Wonderful. Thanks so much for sharing that. I'd like to turn it over to Dr. Antonia Wolf. Dr. Wolf will be talking to us about HER2 positive breast cancer. And just be patient for me for 1 second, and I'm going to share my screen with everyone. Okay, Dr. Wolf, are you there?
Yes, I am, and I think I'm unmuted, and I believe my video is on as well. Would that be correct?
That's what we say. Wonderful. And hopefully you see slides that are up. Is that correct?
I do very much.
All right, let's get started.
Wonderful. Thank you, Alyssa. Thank you to you, Dr. Shang Smith, and the others for organizing this. I want to thank Ms. Randall for joining us. Shante, it's really, really important to have the patient's perspective. I often, we are all clinicians, so myself, Drs. Nunes, Fadi, and Dee, who are joining us today, I think we are all not only clinicians and researchers, and the voice of the patients, the voice of the patient advocates, they do keep us honest. There's no question about that. But also, I think we need to remember that we are also, to some degree, humans as well, or maybe to a lot of degrees. And to some extent, a lot of the anxieties that all of you, patients, caregivers, those of you who have loved ones affected by breast cancer, or yourselves affected with cancer, I think we are having anxieties as well as ourselves dealing with COVID-19. But many patients have reminded me that essentially perhaps we clinicians can understand what patients are dealing with in terms of anxiety and the unknown on a daily basis. So it's almost as if we clinicians are having COVID without the cancer. But at the end of the day, I think we are all doing our best to help you. Cancer doesn't take a vacation during COVID. And I think our group has worked very hard to continue to take care of patients and slowly to be able to ramp up our ability to conduct important cancer research that needs to take place. Alyssa, if you could move to the next slide. So I'm going to touch on HER2 positive disease. Each of us speakers will touch on different aspects, and they are going to be very complementary at the end of the day. And I think the thing to keep in mind is, as you may all know, breast cancer is not just one disease. It is an umbrella, as we call it, of phenotypes. And the subtypes of breast cancer, they matter because they help us define treatments. We need to know what is the subtype of cancer that is affecting an individual patient so that we can make decisions about the treatments we are going to be recommending. That requires high quality, what we call biomarker testing, to make sure we know what is the subtype of cancer, of breast cancer, that is affecting an individual patient. And there has been a lot of work done by our group and many others so that today we have the most accurate diagnosis so we can identify how to most optimally treat someone with a new diagnosis of breast cancer. Next slide. So HER2 positive disease is actually one example where research and a better understanding of biology has paid off enormously. It's really amazing to see that it has been about 30 some years since the 32 years since we learned that HER2 was a marker of poor prognosis. And the question became apparent to some whether that a amplification of the gene HER2 observed in a subset of breast cancers could actually be a target for treatment, would be a driver of disease activity in some patients. And if we could manipulate the HER2 pathway, we could change the behavior of an otherwise aggressive subtype of breast cancer. And in fact, the answer is yes. In 1995, we had data. So essentially 25 years ago, we had data to show that the antibody trastuzumab could help patients with disease that was progressing despite all other treatments. This led to the randomized clinical trials in 1998 showing a survival benefit in advanced disease. This led to the approval of the antibody trastuzumab for the treatment of patients with HER2 positive advanced disease and launching in the early 2000s of the first generation of adjuvant trials. And finally, in 2005, so essentially 15 years ago, essentially the data showing that trastuzumab also improve outcomes for patients with stages, especially stages 2 and 3 disease, and also a suggestion that for patients with stage 1 disease. This was a very fast development of a new biomarker, of a new drug, and then moving into the adjuvant setting. We're enormously grateful to the support we have received from the community, from patient advocates, from many patients and their families and loved ones who have supported organizations like Susan G. Komen, the Breast Cancer Research Foundation, because the research funding coming from those venues have also helped us enormously. Next slide. So but also despite the good news, I think we knew that unfortunately for a lot of patients with advanced disease, many patients, despite having initial response to treatments like trastuzumab, were having disease progression. And so very rapidly, we saw the approval of a whole new generation of drugs, such as lapatinib, which is a tyrosine kinase inhibitor, a small molecule given orally as a pill. Next slide. We also learn about very quickly that there was value of continuing HER2 targeted therapy. For the most part, it appears indefinitely. For many therapies we use in breast cancer and other diseases, once you progress, we would stop and move on. We learned that it is important to continue to target the HER2 pathway. And a number of studies that have been published in the last 10 years have allowed us to understand that continuing targeting the HER2 pathway with different HER2 targeting drugs would be important. Next slide. We learned about another antibody called pertuzumab, which targets another Herceptin in the HER family, the interaction between what's called HER2 and HER3. And we have now learned that combining trastuzumab and pertuzumab, in some patients even doing that up front, can help improve survival. And this combination rapidly came into the adjuvant setting. Next slide. We have learned about other combinations of antibodies, what's called antibody drug conjugates or ADCs, where now we are using the antibody trastuzumab not as a drug itself, but as a vehicle, a transport for a otherwise toxic chemotherapy drug. But if we combine it in small doses to trastuzumab, we can see now trastuzumab carrying the drug directly to HER2 positive cells with a more, hopefully less toxic and more specific way of giving medications. And we have seen this drug TDM1 essentially rescuing patients with HER2 positive advanced disease that otherwise no longer responding to medications such as trastuzumab, but having a significant clinical benefit and a survival benefit with the combination with a chemotherapy drug as an antibody drug conjugate. Next slide. And so this busy slide actually tells us that the first 15 years, a lot happened, and a lot more happened in the second 15 years of what we call the HER2 clinical era. So pertuzumab has been approved. TDM1 is also now approved. Another drug, neratinib, was approved for patients with early stage disease. And we have seen an enormous amount of new information and new knowledge that has really helped us enormously in the treatment of patients with HER2 positive disease. Next slide. And finally, what we now see, new information as of about 6 months ago, which led to the ultimately the FDA approval, especially of the two of the drugs showing on this table, the oral tyrosine kinase inhibitor tucatinib, as well as another antibody drug conjugate called DS-8201. Both drugs with activity in patients with refractory disease in the advanced setting, and tucatinib specifically with substantial activity in patients with evidence of disease in the brain. So you may have heard about something called the blood-brain barrier, which was observed with a lot of other drugs because we didn't see activity or CNS penetration in the central nervous system of medications. But tucatinib is a drug that offers benefits in patients with advanced disease and CNS disease. And this is ultimately incredibly important. Next slide. And so what we also have now is the development of what's called trastuzumab biosimilars. It's almost as if we are moving into a generic phase of some of these antibodies, which are now being manufactured by other companies, potentially less expensive. And we are beginning to see also formulations of some of these medications being given subcutaneously, which could potentially reduce the amount of time that patients are spending in the clinic receiving IV drugs. Next slide. And I'm actually going to ask Alyssa to move to the next slide as well. This is my final slide, and thinking a little bit about the era of COVID, I think there are a couple of strategies that could potentially be considered. We have to remember that we have medications that are very active. HER2 targeted treatment can potentially be given to patients and even sometimes without chemotherapy. So these are medications that are relatively non-toxic for many patients. So those with metastatic disease and HER2 positive disease fortunately have access to treatments that we could potentially continue to give with some strategies as we are describing there, whether we could potentially space out the administration of the antibodies from 3 to 4 weeks, whether we could stop chemotherapy and continue just the antibodies, whether we could use subcutaneous formulations of trastuzumab. So a couple of different strategies to consider. One mention about the drug DS-8201 is that we are learning how to use it. It's now commercially available. It has this complication, what's called interstitial lung disease, some lung inflammation, and I think we need to be aware of that, especially when patients could be affected by COVID. COVID-19. So let me pause here, and I'll pass the baton. I believe Dr. Fatting
That's
is going to be
correct.
the next speaker.
Yep. Thank you, Dr. Wolf. That was great. Dr. Fetting, I'm going to pass the baton to you to talk about managing breast cancer with triple negative disease.
And I believe Dr. Fatty is unmuted, and he should be able to open his video.
There we go.
There he is.
Hi, Dr. Fetting.
We are not hearing him.
Dr. Fetting, I think you're still on mute. So what I'd suggest is, why don't we go on to the next presenter, which is Dr. Nunez, and then Dr. Fetting, do you want to maybe try to call in to the number? Why don't we start with that? So I'm going to pass it over to Dr. Nunez, who's going to talk to us about ER positive in breast cancer.
Hello, can you hear me?
Yes, thank you.
Okay. I should be on camera as well, although I don't see myself. But thank you for being here with us. What I would like to do during this presentation is to cover some considerations regarding the management of hormone receptor positive metastatic breast cancer during the COVID-19 pandemic. So I'll focus less on treatment and more on these considerations. And what do we know about COVID-19 infection and cancer? And our patients constantly ask us these questions. So at the recent ASCO meeting, 2 cohort studies were reported, one of them including about 900 patients who contracted COVID-19 while having cancer. And 21% of these were breast cancer patients. And the entire cohort, the mortality from COVID-19 was 13%. Now, one very important piece of information that we got from the study were the risk factors driving this mortality, meaning that it doesn't mean that all patients with cancer have the same risk for poor outcomes with COVID-19. But risk factors included being of older age, the number of comorbidities, so having other health issues, having a poor performance status, so patients who are more dependent, less active are at higher risk, and being on active chemotherapy, which could weaken the immune system, were all risk factors for worse outcome with this infection. Next slide, please. So what do we have in mind when we think about treatment options during the COVID-19 pandemic? Some of our considerations pertain to the type of treatment. Is this going to be a home treatment, so pill-based treatment that the patient can take safely at home? Or will the treatment require visits to the infusion center, so increased risk of exposure? What are the side effects of the treatment? Is this a treatment that will likely weaken the immune system, which will raise our concern, either due to the treatment itself or to support medications? We frequently use steroids as part of our support medications. Is it a treatment that is expected to lead to complications that can increase the number of visits to the clinic or to the hospital? So again, all these factors resulting in increased exposure to the healthcare environment, which is what we try to avoid during the pandemic. Then what kind of monitoring do we need? Is this a treatment that will require frequent lab visits and again, more trips outside the house? And finally, how's the general health of the patient, including the age? Are there any associated problems like diabetes, obesity, hypertension, lung problems, because all of those have been correlated in other studies with worse outcomes from COVID-19. Next slide, please. So this slide illustrates the sequencing and the common treatment options that we use in hormone receptor positive metastatic breast cancer. And broadly, most patients will either be treated with endocrine therapy alone or endocrine therapy in combination with targeted therapy, including agents which we will discuss. And when endocrine therapy-based options no longer work, that's when we consider the use of chemotherapy. Next slide, please. So in terms of endocrine therapy, the agents that we use include tamoxifen, aromatase inhibitors, either letrozole, anastrozole, or exemestane, and fulvestrant. Tamoxifen and aromatase inhibitors are all oral medications. Fulvestrant is an injectable medication that's given once a month. And patients who are premenopausal at the time of their diagnosis still receive, in addition to these agents, still frequently receive ovarian suppression. Johns Hopkins has issued guidelines that help us decide on what are the best options that will both result in efficacy but also safety regarding choices of treatment during this current pandemic. And those are the ones that I'm going to discuss in the next slides. So regarding oral endocrine therapy, so tamoxifen, the aromatase inhibitors, or fulvestrant, the recommendations are that these are continued during the COVID-19 pandemic. Although we can consider options then fulvestrant, which is an injectable and again requires visits to the infusion center in situations where we are concerned about increased risk of contracting the infection. Are generic guidelines, and they can be obviously adapted depending on how severe is are the number of cases at each institution and how concerned we are about exposing patients. Next slide. So ovarian function suppression requires the use of injectable medications, including triptorelin, glycerolin, or leuprolide. And the next slide, please. And in order to keep the patients safe during this pandemic, we have recommended some modifications. In principle, we do recommend that patients who are already on ovarian function suppression should continue throughout the pandemic, but we have given the patients the possibility of changing from their monthly injection at the cancer center to a self-injection at home or to an every 3 months formulation at the cancer center, again, to decrease their exposure. And for patients who have yet not started ovarian function suppression before the pandemic, some of them would be appropriate for tamoxifen alone, at least until the peak of the pandemic is over. I would like to stress what Shanti was saying about us not letting the COVID-19 pandemic interfere with optimal patient care. And although these guidelines, again, aim to improve safety, that cannot be at the cost of efficacy, and minimizing treatment visits applies to patients who are stable enough in order to be able to do that safely. Next slide, please. Regarding targeted therapies, we have other factors to consider. So these are added to endocrine therapy quite commonly, particularly CDK4/6 inhibitors, who are currently used in the first-line treatment of metastatic breast cancer in conjunction with endocrine therapy. And these include palbociclib, ribociclib, and abemaciclib. But other targeted agents include also everolimus and alpelisib. They require a pause in terms of recommending their use because of the side effects that can be associated with these agents. So Our recommendations include consider delaying the addition of a targeted agent, including the ones that I mentioned before, in first line in patients with minimal disease burden or who are doing very well with endocrine therapy. And this is due to the fact that these agents either require more frequent lab monitoring, or they can have side effects that can lead to more clinic visits or to hospital admissions due to severity in a minority of patients. We do recommend, however, to continue these targeted therapies in patients who already have initiated them and are stable and doing well. We can also consider sometimes lowering the dose of targeted agent to optimize tolerability, reduce toxicity, and allow for frequent lab monitoring, and we do consider increasing less frequent lab monitoring intervals if patients are already on targeted therapy and have been tolerating it well. In terms of chemotherapy, which is an option for patients with hormone receptor positive metastatic disease as well, the considerations regarding the safe use of chemotherapy apply to all types of metastatic breast cancer, and I believe will be covered by my other colleagues.
Dr. Nunez, thank you so much for that wonderful presentation. I'm going to try to switch back to Dr. Fetting and go back to his presentation, and we can hear about triple negative cancer. Dr. Fetting, are you there?
Can you hear me now?
We can. Thank you so much.
The slides are pretty small. Can you make them larger?
That's going to be adjusted on your screen.
Okay. So thank you very much, Alyssa, for inviting me, and Jenny and Karen. Thank you very much for organizing this. And Shante, thank you for your great opening comments. I'd like to share some ideas on the management of metastatic breast cancer during this COVID-19 outbreak. These are general concepts and apply across the different subtypes of metastatic breast cancer. But I'd also like to conclude with some comments that are pertinent to triple negative breast cancer. So the first thought is that the public health efforts to reduce the spread of COVID-19 make treatment of metastatic breast cancer and for metastatic breast cancer more difficult. It doesn't mean that treatment can't be effective and excellent, but it certainly presents a challenge. And why is that? Well, treatment for metastatic breast cancer requires connection. And you need to be connected in many ways. You need to be connected with your providers, with the treatment facility, with its staff, with other patients. You need to be connected with a lot of ancillary resources. The prevention of COVID-19, however, requires distancing. And I think the challenge that all of our speakers are talking about today, and all of you patients are experiencing, is to find the right balance between connection and distancing. Melissa? So here's something to think about. There's a dilemma between the possibility of a COVID-19 infection and the reality of metastatic breast cancer. And what do I mean by that? You have metastatic breast cancer. There's no question about that. It's a real and pressing problem. It needs treatment. You need care. COVID-19, as serious as it is, and as much as we want you to avoid getting it, is a possibility. And one of the challenges we have is to blend the reality of metastatic breast cancer, which varies by the particular subtype, against the threat of COVID-19. Let me explain that. Triple-negative breast cancer is a very threatening subtype of breast cancer. Patients need care. They need connection. They need treatment. And we need to take or think about taking more risks in order to make sure that the care is good. If you have what Dr. Nunez just talked about, which is the estrogen receptor positive breast cancer, it's not as aggressive, it's not as pressing, and we shouldn't take as many risks. We should be more cautious about COVID-19. Next slide, Melissa. Let's talk a little bit about communication with providers. This has been a big challenge and a big change for all of us. And I think we're all learning to adapt. So what we're all learning to do is to have telemedicine visits. And whenever possible, that seems like a good and safe idea. However, we still need to have in-person visits. We need to have in-person visits when you're having new or worsening symptoms, or when we need to evaluate a response to treatment. We want to use telemedicine and electronic messaging whenever we can, but there is the reality of metastatic breast cancer and the need for connection. Next, please. One thing that has occurred to me in treating patients with metastatic breast cancer during this pandemic and during this time when we are more distant is that there's more responsibility than ever on patients to pay attention to their symptoms and to report them. When we didn't have COVID-19, we could rely on our regular visits, our face-to-face visits, to connect about symptoms and problems. But with the COVID-19 distance, patients need to pay attention. Don't deny symptoms. Reach out electronically, but reach out. Next. This is important. Public health efforts to reduce the spread of COVID-19 make treatment of metastatic breast cancer more difficult, but not necessarily less effective. All the things that I and Dr. Wolf and Dr. Nunez are talking about to enable us to connect during this time of distancing can all still result in superior treatment. Next, please. So this is a topic that is much on all of our minds, and that is reopening. Throughout the United States, here in Baltimore and in Maryland, we are reopening. Why is that? Because the important metrics that the public health officials have been looking at are flattening. There are decreased admissions. And at the same time, there's an increasing recognition about the economic devastation that this distancing and social isolation has caused. So we are beginning to reopen. This is staged. One thing I could say, and I think we could all say, is that reopening restores connection. And for patients with metastatic breast cancer, connection can improve quality of life. We can return to things, to activities, to people that give meaning to life, and pick up our spirits as we're dealing with this metastatic cancer. But COVID-19 is still very prevalent, and patients with metastatic breast cancer are at higher risk for severe infection. I have suggested to my own patients that they develop a plan for personal reopening, for them to identify what they're missing in their life as a result of the isolation, and to try to think about reconnecting and reopening with some of those things that are most important and give their life the most meaning. Nothing will be without risk, but I think it's important that patients not be held hostage and separated from all the things, all the people, all the groups that give their life meaning. Let's focus now on triple-negative breast cancer. So this is an example of a very real and very concrete threat to patients during this period of COVID-19. This is an example of a subtype of metastatic breast cancer that really does require connection. It doesn't mean that you necessarily have to have physical connection, but you need to connect. And one of the ways we're relying on doing this is by electronic messaging, by televideo connection. One of the things we need to think about is how often do we need to do certain kinds of practice? How often do we have to have provider visits? How often can we do televideo instead? How often do we need to do those lab tests? Do we need to have counts every week? Can we get by every 2 weeks? In doing this, can we maintain good care, but at the same time, reduce the risk profile? Same thing can be said for radiology. How often do we need to do those scans? Can we do the scans less frequently and still provide excellent evaluation? Next. So let's talk a little bit about chemotherapy. Chemotherapy has been the backbone of treatment for metastatic triple-negative breast cancer. There is, however, no single best treatment. There is no single best chemotherapy. And I think this gives us an opportunity during this COVID-19 pandemic to think carefully about which drugs we should choose. If there's no one drug that is clearly superior for the treatment of triple-negative metastatic breast cancer, can we choose wisely? Can we choose drugs that are less toxic? can we choose drugs that can work at a lower dose than the standard dose? Can we choose drugs that don't require IV treatment every week in the clinic? I think that the answer to this is yes, we can choose wisely. We can come up with effective drugs that can be given more safely during this period of COVID-19. Next. One of the very exciting developments in the treatment of triple-negative breast cancer has been immunotherapy. Immunotherapy is used in triple-negative breast cancers, which express a marker or target on the cancer called PD-L1. Only a small percentage of triple-negative breast cancers express this marker. We have found that a combination of a chemotherapy drug called nab-paclitaxel and an immunotherapy drug called atezolizumab have modest benefits in triple-negative breast cancers which express this target. However, as promising as this is, it has some side effects which give pause during this period of COVID-19. This immunotherapy can cause autoimmune side effects. It can stimulate the immune system to actually attack normal patient tissues. And it can also suppress the immune system. So I think we as a treating community, while on the one hand are hopeful that this treatment will make a difference, we're very concerned about initiating this therapy during this COVID-19 outbreak. One final slide. So here are some other practical things that we can do to try to, on the one hand, maintain high quality care, but on the other hand, limit exposure. Steroids, which are used commonly to prevent nausea, also suppress the immune system and can make you more vulnerable to infection. We want to limit steroids. Going back and forth to your pharmacy to refill your prescriptions exposes you. If we can give you larger prescriptions or use mail order, you're not as often exposed. Many of you have a port, and often the port is flushed frequently. I've learned from our nurses that we don't have to flush the port quite as frequently, so we can keep you from making frequent visits. There are certain medications that we use to support your bones if they're involved with metastatic breast cancer. These are medicines known as Zometa or Exgeva. We don't have to give them as frequently. And coming back to Dr. Wolf's presentation, the trastuzumab and other anti-HER2 therapies can weaken the heart. We get echocardiograms to assess the heart. We can do them less frequently. So I would like to thank you for your attention. And again, like to thank Alyssa and her team for organizing this. All the best.
Thank you so much, Dr. Fetting. That was really great. I love what you were saying about connection. It brought me back to what Shantae was saying at the beginning of the presentation about how important it is to make sure that you stay connected with your friends, with your family, and with your providers. So I thought that was wonderful. I'm going to turn it over to our last speaker. I know we're getting pretty short on time. Our last speaker is Dr. Sydney D, and she is a primary care doctor here at Johns Hopkins. She's going to be talking to us just for a few minutes about supportive care for the metastatic patient during the COVID-19 epidemic.
Can you hear me okay?
I can. Thanks, Dr.
Okay.
D. Lovely to see you.
I'll be very quick because you have these slides, and I think
Wonderful.
a lot of other people have said these things very beautifully. These things are in our heart as we're trying to do our best to take care of you at this difficult time. So just a little bit about what supportive care is. It's about quality of life. It's really about common symptoms and how to try to approach them, especially at this time. We're really trying to give you things that aren't drugs as the first option, and really trying to be thoughtful about side effects, about not doing things that are going to potentially cause harm in your preferences. I have some slides with some services and resources at the end of this, and I guess you'll have access to this later. A lot of great things that are available right now, really, for you to take advantage of. A lot available online, Zoom, all of that. Maya Angelou, I think I said this really beautifully, and I think this is what you've already heard from others, really important to be good to yourself at this time. So I wanted to talk about a couple things, again, that John said really well, but I think some of the things that we're trying to do really to help you as well, to work with, to make sure that hopefully we're communicating, we're not having to send you to the emergency room, we're able to deal with things in a way that is what you want. So it's really important right now, and I've been having a lot of these conversations with my family members and our patients just about knowing what's important to you, who we need to talk to if something happens, to make sure we have all that information. And it's a real gift to your family to not have that burden. There's a lot of materials that have come out about doing this in the time of COVID, and I think the Conversation Project has some really nice materials. This is one of my favorite that's out here. Then again, what John said, don't worry about bothering us. We'd rather know early than have you go to the emergency room. I just had this conversation with a patient this morning. We had to send her to the emergency room last night, and if she had called earlier in the day, we could have saved that. So let us know, and we're trying to do what we can. So I saw her this morning, and I'm going to call her again at the end of the day, and I have weekend information for her to try and keep that from happening again. Really trying to plan, make sure that medications you can have. And if a lot of you are Johns Hopkins patients, we do now have asymptomatic testing available, or if you're having any symptoms at all, it's relatively easy for us to get you testing, and that's something that we've been doing, because often if you're having some symptoms, it can be easier if you have a negative COVID test to get through our system. The next slide is just a couple more points on some of the things we can do. These are the plans that I put together in place with people. What emergency room should you go to if you need it? Can we get you to urgent care? Can I directly admit you to the hospital so you don't have to go to the emergency room? And then, like John was saying, the same kinds of things if you have symptoms or need procedures for symptoms, things like that. Are there things that we can do that aren't going to require you coming in, getting exposed, doing things that might end you up in the hospital? So I think just a couple more points here that things that we truly try to work on, especially right now when there's so much going on, is to really prioritize what's really most affecting quality of life, keeping you from doing what you want to do, which is so important right now. Are there any medicines we can stop or treatments that we can stop? If we're doing things to make sure that we really think it's going to be beneficial and worth all the extra trouble that you're going to need to go through. And we just know that everything's just more difficult and burdensome nowadays. These are just some websites. Again, you'll have the slides, some really good places to get information, including our Cancer Center has a lot of great videos, American Cancer Society, National Cancer Institute. And then on my last slide is some resources. It's just so important to take care of yourself and to talk to people. So these are some resources that our Cancer Center has put together and that we have found are helpful. A lot of these support groups, chat lines, support lines, things like that are really functioning well. And feel free to reach out. I think everybody's just having a difficult time with so many things right now. And there's a lot of great resources that are available to you.
Dr. D, thank you so much for that presentation. I think it was a great way to conclude our presentation, to really look at the whole person and know that you're not just an oncology patient, but we want to make sure that you're taking care of yourself and your overall health and wellness is being looked at as well. I apologize that we don't have time for questions, but really appreciate you joining us. Right here, you'll see a link of a survey. If you could take a minute, click on the link. It'd be great to have you a sense of how we did and how we can improve going forward. And finally, I just want to make you aware of the webinars we have. As I mentioned at the beginning of this presentation, this is a 3-part series. Next Friday, we're going to be talking about breast cancer treatment for patients undergoing early stage breast cancer. And then the following week on the 26th, we'll be looking at breast cancer follow-up and survivorship care in the era of COVID. Additionally, next week, next Tuesday, we'll be doing a webinar, Integrative Approach to Good Health. We'll be talking to an integrative medicine provider. In July, we're going to be talking to a provider about managing sleep and fatigue, something I think we could probably all relate to. And finally, in August, we'll be doing a webinar on mindfulness and meditation. All of these webinars, you can register how you registered for this one. Here's the link at the bottom of the screen. Again, I apologize that this was a little rushed, but really appreciate all of our speakers, Dr. Wolf, Dr. Fetting, Dr. Nunez, Dr. D, and especially Shante. Thank you so much for sharing your expertise and your experience. This has been a great webinar and hope you can join us again in the future. Thank you.